I want to invite Dr. Gaurav Gupta, a dynamic and talented young ophthalmologist from UOC, and has been making significant contribution to the field of pediatric glaucoma. A postgraduate alumnus and has the privilege of training under the esteemed guidance of Dr. Sushmita Kaushik, and he is going to present upon the pediatric MF glaucoma valve implantation. Childhood glaucoma.
A very good morning to all. At the outset, I'd like to thank AIOS and Dr. Rishiraj to include me in this session. For the benefit of session, I'm presenting on childhood glaucoma clinical evaluation and categorization. With this, the aim of my presentation is so that every general ophthalmologist can at least diagnose childhood glaucoma and refer it timely so that we can save these babies. So although rare heterogeneous group of disorder, but presentation varies with the age of onset and severity of IOP elevation. In this, eyeball in children stretches like a balloon in response to increased IOP due to low scleral rigidity, and glaucomatous cupping may or may not be present. So this is very important in children. Glaucoma is not diagnosed with the cupping, but there are other parameters as well. So CGRN defines the childhood glaucoma as per 5 parameters. That is, one is IOP, optic disc cupping, corneal findings, axis length, and visual field. So 2 out of these 5 is required for diagnosis of childhood glaucoma, and if any one of them is present, we need to suspect glaucoma in these cases. So we need, once we suspect them, we need to classify them in primary and secondary glaucoma, because it helps in further follow-up and treatment. Pediatric primary childhood glaucoma is mainly PCG, that is primary congenital glaucoma, or juvenile open angle glaucoma. It depends on the age and presentation. And there may be secondary glaucomas like glaucoma following cataract surgery, glaucomas with non-acquired systemic disease, with non-acquired ocular anomalies, or with acquired conditions. So when to suspect? What are the red flags? So if any infant or young child is there, look for corneal enlargement. Many times we see patients who have large eyes and parents are happy, but always large eyes are not good. So we need to suspect ophthalmos. If there is epiphora, photophobia, blepharospasm, like triad of primary congenital glaucoma, we need to suspect. Older children present with decreased vision, induced progressive myopia, and maybe glaucomatous optic atrophy, may present with eye pain, headache, or color halos. Elevated IOP, corneal enlargement occurs till 3 years, while scleral stretching may persist till 10 years. So axis length may grow till 10 years, but in the less than 3-year-old child, we will see corneal enlargement as well. So this is the standard picture of a primary congenital glaucoma. The child may be having steamy white corneas, and like this, or it may be just large eyes, like in this unilateral primary congenital glaucoma is there. So other clinical examination, we need to look very carefully, look at facial asymmetry, any pigmented patches like in Sturge-Weber syndrome. If the child is small, then we can do a torchlight examination or a clinical photograph, which helps in seeing. We can plan EUA for suspicious cases. If the child is older, then slit lamp examination, gonioscopy, applanation, tonometry, and posterior segment dissection, like standard examination, are required. So once you are planning an EUA, that examination anesthesia, you should have everything ready. Like you need to have a 20-day lens, indirect ophthalmoscope in your OR, direct gonio lens to look for the angles. You need to have a portable pachymeter, portable Perkins tonometer, and preferably a skin in OTs to measure axial length. So this is how a normal infantile angle look. It look very different from an adult angle. We need to know the normal anatomy in child angle also. We need to have a detailed sheet in which we need to document everything about iris pattern, IOP, if there are any drugs, corneal, any stria is there, what is the cup to disc ratio, other fundus findings, CCT, axis length. We need to always plot axis length because many a time these children shows normal IOP, but axis length keep on progressive due to stretching, because when there is stretching, the IOP do not raises, but the axis length keep on raising. So we need to plot them on axis length chart. If there is a progressive axis length increase, it shows that the child is progressive of glaucoma. So here we can see this is the right eye is showing an like a high iris insertion, and the left eye is a normal childhood angle. So we need to look very carefully. If the child is older, we can do ancillary investigation like USGB scan, biometry, keratometry, axial length retinoscopy, visual field if the child is adult. So many child can easily do perimetry. We think they are not able to, but they can do. This is a very important flow chart for categorizing the children. If any like 5 things are present, we are suspecting or diagnosing glaucoma, then ask if the child has undergone any cataract surgery. If not, then look for any systemic findings. If not, look for ocular anomalies. If not, ask for history of any trauma, steroid use, uveitis, any other secondary cause. If not, then look if the child is having ophthalmos. If not, then the child is the case of like juvenile open. Like all these questions will help us in categorizing these children. So I'll be showing few pictures of ocular anomalies like Axenfeld-Rieger syndrome. These are very classical in this on correctopia, polychoria, and on gonioscopy there is a Y-shaped pattern of iris. This is the case we reported, and this, there was 360-degree posterior embryotoxon. This is a case of Peters anomaly. In Peters, the very important thing I want to highlight that all eyes will appear white. So every white is not same. We need to look very carefully in this Peters anomaly. We can see peripheral clearing and central clearing. You can see there is a central clearing over here. So this is the hallmark of Descemet membrane defect in corneal endothelium. These are the other pictures. Here you can see very nicely central clearing. This central clearing is the diagnostic of Peters anomaly, because on UBM when you will see this central area will show posterior Descemet defect and posterior stromal defect. Then another is aniridia. And aniridia, there is complete loss of or any loss of iris as suggestive of aniridia. We need to look for other phenotypes, any iris changes. We need to screen them for Wilms tumor. We need to look for any foveal hyperplasia, nystagmus, or any other things. But not always complete loss of iris. There are grading of ABCD, like even a small amount of iris atrophy or a stump of iris. There are other phenotypes of aniridia as well. So there is a very important role of imaging in this case. This is like this is the case of unilateral PCG, right eye is normal, left eye is ophthalmic. On like OCT, you can see this is a normal angle, but here the iris is highly inserted. So it helps in diagnosis. Another case of late onset PCG. Late onset PCG is those like children presenting late at 3 and 4 years, but they have ophthalmos, they have large corneas. Here also you can see the iris is very highly inserted. Due to high iris insertion, it shows that there is trabecular dysgenesis and there are chances of glaucoma. Like this is the case of neonatal onset Peters anomaly. There we can see on UBM there is a posterior segment defect, and here in the second case the iris is also inserted over there. This both eyes are appearing very much similar, but on UBM when we saw there is like posterior segment defect in the one eye, and other eye we have nice Descements. So how does it help? If there is a Peters anomaly, there is posterior segment defect. Even after doing surgery, the visual prognosis will be guarded. We might be needing transplantation in those cases. But if there is intact posterior segment and posterior Descement, then doing a CTT or doing a glaucoma surgery in those cases will completely clear up those cornea. So it helps in prognosticating these cases. So this is another case of congenital primary aphakia. Here we can see it is appearing white, but on UBM we can see there is no lens inside. These are cases of phakia, and if we give them plus 10 diopter, the child can very well see there is no glaucoma in these cases. So take-home messages: childhood glaucomas has varied phenotypes, and good clinical examination can help categorize them very easily. We need to diagnose and categorize them in proper format so that we can prognosticate them, we can follow them. And a CGR and classification should be done for each case, and use the best way to clinically evaluate small children. And very important that we need to tell them that post-operative lifelong follow-up is vital. It's not like one-time surgery. We need to follow them very carefully. So I would like to acknowledge my mentors, Professor Sushmita ma'am, Professor Pandav, and whole team ACPGI for my work during my PGI time. So thank you, everyone.
Thank you, Dr. Gaurav, for excellent